Okay, welcome back, everyone, to our next session at the Mid-Atlantic Virtual Summit. My name is Matt Rayner, publisher here at Healthcare Innovation. It is now time for a featured presentation from the HealthShare Exchange. Today, we are being joined by Bill Morella, Director of Data Analytics and Quality from HealthShare Exchange. And Bill will be discussing how HealthShare Exchange has been supporting the Delaware Valley's COVID-19 response. As a reminder, if you are choosing to watch this content live, first of all, welcome. All of these sessions are designed to be interactive. If you have a question for our faculty today, please do not be shy. Just submit it through the chat box within the Zoom platform. We'll do our very best to get to all of the questions today. Okay, with that said, I would love to bring Bill on now to begin the presentation. Bill, the floor is yours to take it away.
All right, great. Thank you, Matt. Welcome, everybody. Thanks for joining us today. So for those of you who aren't familiar with HealthShare Exchange or health information exchanges in general, let me just tell you a little bit about what we do and what our role is in the healthcare system. So think of HSX as sort of being the railway network for all the healthcare data that's being generated and shared among your healthcare providers, your health plans, all the other facilities, the labs that you deal with, every place that you receive care. Basically, HSX's role is to move patients' data to the point of care where it's needed. So to give you some concrete examples, if I wind up in an emergency department at a health system that I've never been to, they would be able to pull up a basic medical record about me by virtue of HSX's services. Another example is if I do wind up in an unfamiliar hospital, my primary care doctor will find out about it through an encounter notification service that we run. So there are about 80 HIEs around the country. HSX is one of those, and our catchment area is primarily southeastern Pennsylvania, northern Delaware, and southern New Jersey, so which we describe as the Delaware Valley. So you can see on this slide, that we're trying to get to the point of care, which in our case means we're trying to get into the electronic medical records that clinicians already use. Some HIEs took an approach of trying to get busy clinicians to use their portal and to use some of their web-based tools, but we found that the more effective path is to really integrate your data directly into the electronic medical record so that you're in the clinician's workflow. And we've integrated with about 40 different EHRs at this point. So in our area, I guess we've been operating and moving the data around since about 2012. And part of what has enabled us to do that is the cooperation and support of our members. So many HIEs around the country were started by the state government, started by a Department of Health or something like that. In our case, we were started really by the payers and the providers in the greater Philadelphia region. So you can see all of them, or many of them, in the middle of this slide here. And we are governed by these organizations. So our members advise us on the strategic direction for the organization. They keep us very close to their needs and what we should be doing with the data on their behalf. And part of the reason that they trust us to do this, aside from at this point our continued performance, is we are one of a handful of HIEs that have gotten high trust certified. So you can see that logo in the bottom left-hand corner. This is a third-party validation of our security infrastructure, policies, procedures. Most of the people who get that certification are EHR vendors. We're one of a handful of HIEs that have also gone to that same level. The program that I'm going to tell you about today and talk a little bit about our COVID response has enabled us to do services for state government, county departments of public health, and others who are non-traditional recipients of HIE data. So I'll talk more about how I guess one of the silver linings of the pandemic for us has been the ability to showcase what HSX and other HIEs are capable of, and how we can support public health needs in a time of crisis, as we've seen over the past 2 years. So I talked a little bit about our geographic network. I'll also point out we've got about 12 million patients at this point in our clinical data repository. So most of these people, if they've lived in our geography for any length of time, we have a longitudinal healthcare record that spans all the providers and all the payers that they may have dealt with over, whatever period they've been in this area. We've got about 16,000 physicians and other clinicians who are users or receive data from HSX. And we've got about 450 different organizations that are connected to us in one way or another, either receiving data, contributing data, or supporting the data that we provide to others. So for most of HIE's evolution, and they've been around probably for about maybe 15 years or so, most of that time, the core function of HIEs has been moving data around about individual patients, sort of at the point of care, so that a clinician knows more information about the patient in front of them or has access to care they may have received elsewhere. And it's very transactional in the sense that it's kind of focused on one patient at a time. What we've been doing over the past several years is focusing on higher order things. Not that the individual patient's data is not important, it is, but that is sort of the core function. We're now getting to the point in our evolution where we can achieve these sorts of population health or group level outcomes. So to give you a couple examples of how we're doing that with the data, we are supporting several diabetes prevention collaboratives that are going on in our area, working with the American Diabetes Association, Jefferson College of Population Health on the No Diabetes by Heart initiative of the ADA. And with Jefferson, we're focused on prevention of diabetes by identifying for the health systems which of their patients are eligible for diabetes prevention based on their lab results or based on clinical diagnoses. Another example is one that we're doing with the Department of Aging, where we are screening people shortly after hospitalization for whether they might meet the criteria for different benefit programs they may be eligible for. The main one that we're concerned about is PACE. It's a low-cost prescription drug program that is run by the Department of Aging in Pennsylvania. But at the same time they're being screened for that, people who call into that program are also being screened for 19 other benefit programs at the same time. SNAP, which is food assistance, LIHEAP is utilities assistance, and even finding people who may be eligible for Medicare or Medicaid who are not yet enrolled. So that's, the health systems are excited to participate in this project because it helps us support their patients getting better health outcomes. And then finally, COVID-19. So we established a COVID-19 registry early on during the pandemic, and we are continuing to support our members. And I'll tell you about that program in detail. So one of the initiatives that we started and is helping us really perform for our members during this time is the Office of the National Coordinator for Health IT established what they call the STAR HIE program. So this was offered to the 80 HIEs around the country, and we had to submit competitive proposals, and we were one of 5 HIEs in the country that was awarded this initial grant. They have since added more to, I think, bringing the total up to about 23 HIEs that are contributing data around vaccinations. But the original group was focused on basically building new services within their HIE that would benefit public health agencies in their effort to combat COVID-19. And while the focus of this is on COVID, obviously, many of the services that the HIEs proposed and the functionality that we're putting in place is meant to persist beyond the current COVID emergency, so that God willing, something like this does not happen again for a long time, but that next time we would be better prepared by virtue of standing up some of these new services. So each HIE's program around COVID is a little bit different, but what we proposed was identifying some new opportunities for data exchange that based on the public health priorities, sharing the COVID data that we had that was coming in from our members with all the public health agencies in our area, and then enhancing that data for use by public health. So I'll show you some examples of how that plays out. And then, as with anything, there's a standard sort of, project management, program management aspect to it. But for us, the governance aspect is about expanding the legal scope of what we are able to provide. And, the core data that all HIEs deal in is for treatment and care coordination purposes from a HIPAA perspective. But some of the programs that we're putting in place are beyond that treatment and care coordination and get into these kinds of population health, public health uses of the data. And we have to put in place the appropriate governance tools to allow us to do that. So some of the data connections that we've established. So many of our members use HSX to report electronic lab results to the public health agencies. And others who were sharing that data with the state were not necessarily sharing it with the city or the county departments of health. So we were able to take existing data feeds under electronic lab results and basically fork those data feeds to all the public health agencies that were able to ingest it. That resulted in more timely data, and for during the period when contact tracing was the focus, literally every hour matters. And in some cases, we were able to send real-time data feeds to the public health agencies that were used to getting daily or weekly batch feeds from some of our members. Electronic case reports, I'll talk about more in a moment. And then CDAs, clinical document architecture documents. So these are documents that you would be familiar with. If you have been hospitalized, you would get a discharge summary at the end of your hospital visit, or even if you go to the doctor, the printout that they give you at the end of your doctor's visit, summarizing your diagnoses, any drugs that were prescribed, any referrals that they were making for follow-up tests. All that information is the kind of thing that comes to HSX and the other HIEs. And that very rich medical history information has also been part of what we're able to share with the public health agencies just around COVID. So electronic case reports. Now this is a very new technology that is just beginning to roll out across the country. It's been done in a few pilots, but we're now trying to operationalize this across our whole membership. So this is a new health IT standard that is going to be the future for communicable disease surveillance. The way surveillance happens today is very manual. It is electronic, but it still results in a lot of manual processes. And we've spent literally billions over the last 10 years making the healthcare system interoperable and getting everyone's health data into electronic form. And now that we have all these electronic medical records throughout the whole industry, we're now in a position to stand up applications that sit alongside the electronic medical record and actively look for patients who might meet the criteria for one or more communicable diseases. So the way this works is a kind of a busy diagram for the process, but this basically is an application each provider organization can enable within their EHR that will send data out to an external knowledge repository where the data is screened against the rules around all the public health agencies that would have access to that patient's data based on where they live and where the care is being delivered. And if it in fact does meet the definitions for one or more communicable diseases, and every public health agency has a different constellation of diseases and different decision rules around that. If it does meet their definition, a reportability response will go back to the provider organization telling them that it was reportable, or it'll tell them that it was not reportable. And HIEs are brokering these transactions and are able to get people up and running on this system much faster than they would be able to otherwise. So something else that we've been doing since the very beginning of the pandemic is monitoring at a very granular level the diffusion of cases and the incidence of new cases of COVID-19 as they've come in. This was a real challenge in the beginning of the pandemic because those of you who are familiar with how coded data works in healthcare, there were not diagnostic codes that were specific to COVID in the beginning of the pandemic. We had to scramble, and the EHR vendors and the providers we work with had to scramble to get new codes in place so that we could monitor this proactively. But you can see that this, I'm sure that we don't find every case in our HIE, but the data here corresponds very, very closely to the timing of the surges that we saw in the greater Philadelphia region. And all of our members were reporting data to the public health agencies, in some cases several times a day, around how many people they had in-house with COVID and how much PPE they had on hand. And for some of this information, we were able to track this and share data back to the providers. So, and in the beginning stages of the pandemic, this kind of information was scarce to come by. To give you another example, and this is a good illustration of how you can use data from HIEs for these kinds of population health surveillance activities. In the very beginning of the pandemic, we were a couple of weeks behind New York, so we sort of had a little bit more warning than they did. So what you see on the left-hand side of this chart is a lot of the facilities emptying themselves out of non-urgent admissions and canceling elective procedures. And the lines here, the green line here is admission or discharges, and the red line is admissions. And in the beginning of the pandemic, you can see the admissions are overtaking the discharges on most days of most weeks during the beginning of the pandemic. After we hit that peak, you can see the pattern reverse, and you actually have more discharges occurring each day than the new admissions. So fortunately, we did not get overwhelmed in terms of the volume of care, but we were able to monitor this at an individual facility level and share that data with our members so that people would know that, if I get into trouble today and my ED is overwhelmed, I can send patients to, a hospital down the street or across town. So something else that we did was look at COVID risk factors. So we implemented a COVID risk index that looked at the chronic conditions that people would have that would make them at increased risk should they get COVID. So it's not about how likely are you to get it, but it's about what would your prognosis be should you get COVID. So for every person, we were able to index their risk for things like hospitalization, mortality, length of stay, and generally we saw that the more risk factors each person had, the greater their risk. So if you had 3 or more of the risk factors we were looking for, you would have twice the risk of hospitalization and 4 times the risk of dying. So just using the data for this kind of higher order population health purpose is has certainly borne itself out. Something else that we did that is really innovative is we stood up a dashboard that would help the Office of Emergency Management monitor the volume of activity at all of our member institutions in near real time. So this was updated hourly during the course of the pandemic. And what we were looking for was any surges in activity at particular hospitals. So, this is simulated data that I'm showing you, but to give you an example of how it would work, we were looking for whether there is a significant increase in activity based on what hour of the day it is, what day of the week it is, what site it is, and what their normal volume should be, and highlighting for them any organizations that were seeing surges, over the last hour or several hours. And now, that will be really useful for things like a train derailment or a chemical leak, both of which have happened in our area, not in the too distant past. COVID is more likely a slow growing surge. So, of course, we have other views to look for increases in volume that would take place over that kind of a time period. Of course, now the focus is really about immunizations and has been for some time. So we're doing really well with our immunizations in the greater Philadelphia region, and we're reaching the goals that have been set for this. And this just gives you an example of what the data looks like in HSX. So it's really important that you are able to track specifically what vaccine someone was given, which manufacturer's dose were they given. We're able to see exactly when it was given so that we know if people are lagging getting their second dose, if it's a version of the vaccine that requires that. And we're able to monitor this in real time so that we are able to keep up with people's vaccination status. And that's been really important in the data that we've been sharing with our membership. So this just gives you a little bit of a view of the immunizations we are able to see. So, you can see we kind of reached our peak there early in March, and the numbers have since been declining, but we are able to distinguish between people's first and second doses. We are able to see the sort of a general view across the region of where the doses are concentrated and which members are sending that data. So now this is not a complete view of all the vaccinations that have occurred. The data that we're getting is primarily coming from our members through the CCDA documents that we were talking about earlier. So this is coming in as a summary of the episode, and the vaccine data is coming along with that. We've been talking with the public health agencies about integrating with the vaccine registries, and would like to be able to do that, but we'll have to see if that bears out. There are some logistical issues around their ability to share that data with us. But what our members are asking us to do is to keep them apprised of their members' vaccine status, because they and the public health agencies are doing outreach to people who are not yet vaccinated and really should be based on their risk. So in addition to sharing people's vaccine status, we are also identifying their COVID risk. We talked about the risk index a few slides ago, and also identifying people who may be homebound based on recent diagnoses suggesting that they need help with activities of daily living, or they are wheelchair bound, and things like that, so that some of our members are sending visiting nurses to people's homes, or sending EMS to people's homes in order to get them vaccinated if they can't get to a vaccine site. We are also beginning to monitor for vaccine-related adverse events, and also looking at vaccine effectiveness. There have been a handful of cases that we're aware of vaccine breakthrough, where somebody gets vaccinated, but they still wind up getting COVID despite that. And we're also monitoring for vaccine distribution equity. Fortunately, HSX was in a position to share with all the public health agencies our patient demographic file. So I mentioned before, we've got 12 million patients in our database, and we actually had better race and ethnicity data than the public health agencies had during the beginning of the pandemic. They were managing the COVID response based on primarily on lab reports, which are sort of the gold standard in terms of disease surveillance. But those lab reports frequently contain very little contextual information about the patients. So you might not know the patient's age, whether they were hospitalized, what their race was, and whether they died as a result. All the other things that you would want to know to provide context around those lab results was missing. And we were able to share that data with the public health agencies so that they could also monitor for disparities, not just in vaccine administration, but earlier on in the pandemic in terms of testing. So we've had a number of challenges. So I talked about the importance of having properly coded data, and the other issue that we have around that is delays in coded diagnoses. So typically, particularly with hospital care, the coding of an encounter may not happen until up to 3 days after discharge. So we really didn't know at any point in time. We couldn't definitively say that a person was admitted with COVID symptoms sometimes until their encounter was over. We've also, as I mentioned, we've had some barriers integrating with the regional vaccine registries. Their preference is for people to log into their system directly and look people up one at a time, which is unrealistic for many busy clinicians. What we've proposed to do, and we are doing with the vaccines we know about, is do batch queries and provide our members with constantly refreshed data on their whole membership. The idea of looking people up one at a time is pretty antiquated, but the reality is many of these vaccine registries many of them are 20 years old, may have been homegrown systems, and really were not designed to support the kinds of bulk queries that we're doing. And then, of course, we have many non-traditional sites for testing and for vaccination, and tracking people in those settings is a big gap that we have right now. And so those are things that we're working on so that we're in a better position the next time something like this comes around, and just being able to increase our coverage and stand up new connections much more quickly in the future than we have in the past. So I'll stop there just in the interest of time and invite any questions. Matt, have we had anybody type into the chat?
Bill, not yet. Audience, any questions for Bill on his presentation today? Silence is always a good thing, Bill. It probably means you said everything that needed to be said. There is Bill's contact information. If you do have questions on the presentation today, or if you're choosing to watch this content on demand, feel free to reach out to Bill. Bill, I do want to thank you. I thought this was a great, informative presentation for our audience, the Mid-Atlantic audience. And here is a question from Pascal. Do members have to agree to sharing of data with various entities?
Yeah, great question. Thank you. So yes, they do. So basically all of our members have signed a participation agreement, and they've signed essentially the same participation agreement. So think of HSX as the hub in a network of all these parties that have agreed to share data under a common set of rules and terms and uses of the data. So we're constantly expanding what uses the data can be put to, but that, obviously that is done with members' consent, and they help us shape those use cases. The other thing I'll comment on that's related to your question is about how patients figure into this. So, what are we allowed to do with patients' data, and what control do patients have over it? So Pennsylvania, like most states in the country, is what's called an opt-out state for HIE purposes, which means that everyone is presumed to consent to their data being shared for these kinds of activities, but they do have an opportunity to opt out. So we only get, I want to say maybe 200 opt-outs a year, but we do have a way in our system to handle those and to suppress people's data from going downstream from HSX if they have opted out with us. They can always opt back in, but that's how that patient consent aspect of it is handled.
Thank you, Bill. Okay, I think that will conclude the presentation for today. Again, Bill, I want to thank you. But this was very informative, and very informative for our audience of Mid-Atlantic healthcare executives. Okay, we are now on a one more very small break. We'll be resuming here at 12:45 Eastern Time for our final session of the day, a featured presentation from Class Research. So we'll see everyone back on here at 12:45, and thank you, and see you shortly.